thank the organizers for inviting me to present on epilepsy. The purpose of neuroimaging in the context of epilepsy surgery evaluation are to identify the epileptogenic substrate, localize the eloquent cortex and white matter tracts, and assess the epileptogenic zone. The lesions can be identified in up to 80% of patients with focal drug-resistant epilepsy. The range of lesions that may be identified in children is similar to that in adults. However, in children, malformations of cortical development, including focal cortical dysplasia and developmental tumors, are much more common and account for about 70 to 80% of the pathologic substrate. On the other hand, in adults, hippocampal sclerosis account for about 70 to 80% of the pathologic substrate in adults, whereas in children, hippocampal sclerosis accounts for about 10 to 40% of the pathologic substrate. Other lesions that may be encountered include Rasmussen encephalitis, Sturge-Weber cavernoma, and encephalocele. About 15% of patients have dual pathology, including focal cortical dysplasia and hippocampal sclerosis. Focal cortical dysplasia is one of the most common lesions responsible for drug-resistant epilepsy in children. It is also one of the most challenging lesions to detect, as the MRI features are frequently subtle. About 50 to 80% of focal cortical dysplasia have been reported to be missed on MRI. By improving the detection of focal cortical dysplasia, you increase the likelihood of achieving seizure freedom after surgery and could potentially change pre-surgical planning, in particular intracranial EEG planning. The MRI features of focal cortical dysplasia include thickening of the cortex, blurring of the gray-white matter junction, high T2 and flare signal in the subcortical white matter and cortex, and tapering of the abnormal signal towards the ventricle, which is fairly characteristic of FCD type 2B. Other features include high T1 signal in the cortex and abnormal sulcation and gyration pattern. The International League Against Epilepsy has classified focal cortical dysplasia into 3 categories. Type 1 and type 2 lesions are isolated lesions. FCD type 3 has focal cortical dysplasia type 1 associated with an additional lesion such as hippocampal sclerosis, epilepsy-associated tumors, vascular malformations, or other lesions. FCD type 1 has abnormal radial and/or tangential cortical lamination. FCD type 2 has cortical dyslamination and dysmorphic neurons. Type 2A does not have balloon cells, and type 2B has balloon cells. This is an example of a patient with FCD type 1. The lesion is within the left anterior temporal lobe and demonstrates increased signal on both flare and proton density. This is another case of FCD type 1, but in an infant. The imaging findings include thickening of the cortex, atypical sulcation and gyration pattern, lower T2 and higher T1 signal in the subcortical white matter. The changes in the signal intensity of the white matter is thought to be related to accelerated myelin maturation. Moving on to FCD type 2B, also known as Taylor's focal cortical dysplasia or focal cortical dysplasia with balloon cells. Imaging features include a lesion with a broad base that involves the cortex and tapers towards the ventricle. Contrast this with perivascular space, whereby the lesion is linear, i.e. it is not broad-based, and extends from the gray-white matter junction towards the deep white matter. FCD type 2 is said to have better seizure-free surgical outcome compared to FCD type 1. About 10 to 20% of FCD type 2B has somatic mutation involving the mTOR pathway. This is the most common form of mutation encountered in FCD type 2B. FCD type 2B may also be associated with abnormal mildly phosphorylated form of tau protein known as infantile tauopathies. FCD type 2B, tuberous sclerosis, and Hemimegalencephaly are histologically similar. The main distinguishing features are the number of lesions and the extent of the lesion. FCD type 2B has a single lesion that involves a single gyrus up to 2 lobes. Hemimegalencephaly involves at least half of the hemisphere. Tuberous sclerosis is the syndromic form of FCD type 2B and has multiple lesions. All these three entities may have somatic mutation involving the mTOR pathway. So earlier on, I've alluded to the fact that the most common form of mutation in FCD type 2B is somatic mutation involving the mTOR pathway. However, occasionally you may come across germline mutation involving the DAPDC5 mutation. So let's move on to look at a subtype of focal cortical dysplasia known as bottom of sulcus dysplasia or BOSD. This can either be FCD type 2A or FCD type 2B. Bottom of sulcus dysplasia are generally smaller compared to focal cortical dysplasia that involves the surface or the gyrus of the brain. Because they're subtle, they're frequently overlooked on MRI. In our series, nearly half of the cases were overlooked by the reporting radiologists. It is important to identify bottom of sulcus dysplasia as these patients generally have good seizure-free surgical outcome after resection. Seizure freedom following resection of BOSD has been reported somewhere in the order of 80 to 90%, whereas with other subtypes of focal cortical dysplasia, it varies between 60 to 70% seizure freedom rate. So on this slide, I've shown you 6 different examples of bottom of sulcus dysplasia. As you can see, the lesions are small and they are subtle. Hence, it is not surprising that in 4 out of these 6 cases, they were initially reported as normal and were subsequently identified on second review of the MRI or on repeat imaging using higher resolution techniques. So let's move on to FCD type 3, i.e. dual pathology. In this particular example of a patient with right temporal lobe epilepsy, there is a lesion within the right amygdala, which turns out to be a low-grade astrocytoma. If you look carefully at the right superior temporal gyrus, there is subtle increased T2 signal in the right superior temporal gyrus, and histology from this location shows FCD type 1. Hence, this is a case of FCD type 3. The MRI appearance of focal cortical dysplasia may change with time due to increased myelination with brain maturation or due to seizure-related changes. The International League Against Epilepsy has indicated that there is an unfavorable time window, typically between the age of 6 months to 2 years, at which time a lesion such as focal cortical dysplasia can be masked because of increasing but yet incomplete myelination. They have recommended repeat imaging every 3 to 6 months and, if tolerated, after the age of 2 years. In my personal opinion, I think this is rather excessive and we do not have the resources to do that many repeat imaging. I would normally recommend to our neurologists that we repeat imaging after the age of 4 years when myelin is more mature on both flare and proton density if tolerated. However, if the child has severe drug-resistant epilepsy requiring more urgent surgical intervention, then I'll recommend repeat imaging at any time point. This case demonstrates the evolution of focal cortical dysplasia with brain maturation. At 8 weeks of age, the lesion is really obvious in the right frontal lobe. However, at 5 months of age, the lesion became less conspicuous. This phenomenon has been termed as the disappearing focal cortical dysplasia. Please note that there are mimics of focal cortical dysplasia, including astrocytic inclusion, also known as filaminopathy, and oligodendroglial-like cells. There are various terminology associated with oligodendroglial-like cells, including oligodendrocytosis, oligodendroglial hyperplasia, mild malformations of cortical development with oligodendroglial hyperplasia, also known as MOGHI. The imaging appearance of astrocytic inclusion is very similar to focal cortical dysplasia. The main distinguishing feature is the clinical presentation. Patients with astrocytic inclusions are more likely to present with periodic spasm compared to those with focal cortical dysplasia. The imaging appearance of oligodendrocytosis is also very similar to focal cortical dysplasia type 1. In fact, some patients may have dual pathology of oligodendrocytosis and FCD type 1. Seizure-free surgical outcome following resection of oligodendrocytosis is also very similar to FCD type 1. So let's move on to another lesion, hemimegalencephaly. As the name implies, one hemisphere is bigger than the other hemisphere. The cortex is dysplastic, it is thickened with abnormal sulcation and gyration pattern. In older children, the white matter demonstrates higher T2 and lower T1 signal due to the presence of gliosis. In contrast, in neonates and infants, the white matter demonstrates lower T2 and higher T1 signal due to the presence of accelerated myelin maturation. About 30% of patients with hemimegalencephaly may have somatic mutation involving the PI3K, AKT3, and mTOR pathway. Hemimegalencephaly may be isolated or syndromic. Syndromes associated with hemimegalencephaly include hypomelanosis of Ito, megalencephalic capillary malformation syndrome, tuberous sclerosis, and Proteus syndrome. So moving on to tuberous sclerosis. This is related to mutation involving TSC1 or TSC2 gene. The imaging findings include subependymal nodules, which is present in the vast majority of patients and is frequently calcified. Other imaging features include cortical tubers, which in some patients may show cystic degeneration or may show calcification. Another feature of tuberous sclerosis is white matter lesions along the radial migration line. So let's move on now to look at long-term epilepsy-associated tumors, also known as LEADS. In LEADS, seizures usually occur by the first decade of life. The vast majority of these lesions are benign and they're considered as WHO grade 1. These lesions are slow-growing and involves the cortex and there's no associated edema. Focal cortical dysplasia may be present adjacent to the tumor in about 5 to 10% of cases. These tumors include dysembryoplastic neuroepithelial tumor or DNET, ganglioma, polymorphous low-grade neuroepithelial tumor of the young or plenty, and angiocentric glioma. So let's have a look at each of these tumors. We'll start off with DNET. This is frequently present in the frontal or temporal lobes. They may be wedge-shaped and extends to the ventricle in about 30% of cases. They may have a bubbly appearance due to the presence of multiple cysts. You may see a rim of high flash signal. It has well-demarcated margins. Calcification may be present in 20 to 30% of cases. Because it's slow-growing, you may see remodeling of the adjacent skull bulb, and enhancement may be seen on post-contrast scan. About 50 to 80% of DNET may be associated with fibroblast growth factor receptor gene alteration. So let's move on to ganglioma. This occurs frequently in the temporal lobe. They may be solid or combined cystic and solid with eccentric enhancing nodule. Calcification is present in 30 to 50% of cases, and enhancement is seen in about 60% of cases. The most common mutation encountered in ganglioma is the BRAF mutation. So let's move on to look at polymorphous low-grade neuroepithelial tumor of the young or plenty. This occurs in children and young adults. They commonly occur in the temporal lobes. On CT, they are hypodense mass and frequently contains calcification. On MRI, they are heterogeneous on T2 and flare with salt and pepper sign due to calcification. Usually, this tumor does not demonstrate enhancement. In terms of genetic mutation, the common mutations include BRAF mutation and fibroblast growth factor receptor fusion. So let's move on to angiocentric glioma. This occurs in children and young adults. On MRI, they may have hyperintense rim and may have cystic areas. The lesions generally do not show enhancement. In terms of genetic abnormality, NIT alteration is the most common form of mutation encountered in angiocentric glioma. Sometimes it may be difficult to distinguish between low-grade tumor from focal cortical dysplasia. There are certain features that may help you distinguish between these two entities. Low-grade tumor generally have more mass effect. It may show enhancement, may show calcification, and the white matter may show an area with very low T1 or very low flash signal due to cystic changes. Amongst all these features, I find that the last feature is the most helpful to distinguish between these two entities. Please note that these are just guidelines, they are by no means rules. So I've brought along two cases to show that focal cortical dysplasia may occasionally show evidence of calcification, such as in these two cases. So let's move on to hippocampal sclerosis. This is the most common epileptogenic substrate in adults with focal intractable epilepsy. Imaging features include increased T2 signal and volume loss in the hippocampus. Other features include loss of internal architecture and loss of hippocampal head digitation. In some cases, you may see atrophy of the ipsilateral mammillary body and fornix, particularly in adult cases. In about 40% of cases, you may see abnormal signal in the anterior temporal white matter, and this could either be due to gliosis or focal cortical dysplasia or oligodendrogliosis. Let's move on to meningoangiomatosis. This is a benign vascular proliferation of the leptomeninges and cortex. The lesion and the perilesional cortex are highly epileptogenic. There are two forms of meningoangiomatosis. The sporadic form is solitary and presents with intractable epilepsy. The syndromic form has multiple meningoangiomatosis and is usually associated with NF2 and is generally asymptomatic. On MRI, the lesion demonstrates lower T2 and lower flash signal in the cortex due to the presence of calcification. The white matter demonstrates higher T2 and flash signal due to the presence of gliosis. Occasionally, you may see clumped calcification, and enhancement may be seen in some cases. So let's move on to Rasmussen encephalitis. This is an autoimmune encephalitis. Patients may present with partial seizures or epilepsy partialis continua. With disease progression, there is progressive hemiparesis or hemiplegia and cognitive decline. Early in the course of the disease, imaging may be entirely normal, or it may show mild swelling of the cortex. As the disease progresses, there is progressive atrophy and progressive abnormal signal in the white matter and cortex. The frontal and the frontotemporal lobes are commonly involved, and there may be associated hippocampal atrophy. Please be aware that the lesions in relation to Rasmussen encephalitis may be skip lesion involving a single hemisphere. Hence, on imaging, you may see multifocal abnormal signal within a single hemisphere. As such, biopsy may occasionally be normal. So the case in the upper panel is that from a patient who has had 2 biopsies that were normal, and the diagnosis of Rasmussen encephalitis was made based on resection specimen. So let's move on to Sturge-Weber syndrome. In Sturge-Weber syndrome, there is this is secondary to somatic mosaic mutation of GNAQ. Peel angiomatosis may be unilateral in about 80% of cases or bilateral in 20% of cases. Patients with bilateral pot-1 stain usually present with bilateral peel angiomatosis. Imaging findings include peel enhancement, volume loss in the affected lobes, gyral or subcortical calcification, and enlargement of the choroid plexus. Choroidal angioma in about 70% of cases. So moving on to hypothalamic hamartoma, also known as hamartoma of the tuber cinereum. The presentation include gelastic seizures or precocious puberty. The sessile form is more likely to be symptomatic compared to the pedunculated form. They are isointense to gray matter on both T1 and T2 weighted image, and the large lesions may show increased T2 signal. This lesion does not show enhancement. Hypothalamic hamartoma may be isolated or syndromic. The syndromic form includes Pallister-Hall syndrome. Treatment of hypothalamic hamartoma include MRI-guided laser interstitial thermal therapy. Please note that some patients may present with focal epilepsy, but they are non-surgical candidates. These include patients with metabolic disorders such as POLG1 mutation and autoimmune encephalopathy. POLG1 mutation may present with severe epilepsy, epileptic encephalopathy, and encephalopathy. Imaging findings include abnormal T2 signal with or without diffusion restriction, particularly involving the parietal, occipital, and thalamic region. Other areas that may be involved include frontal lobe and the basal ganglia. Please be aware of this particular condition as sodium valproic acid is contraindicated and death has been reported in those exposed to sodium valproic acid. So let's move on to autoimmune encephalitis. This occurs disproportionately in women. And the most common form is anti-NMDA receptor antibodies. It may be associated with tumors, particularly teratomas of the ovaries. However, in a substantial number of cases, there is no detectable tumor. Patients present with behavior changes, bizarre movements, and seizures. As the disease progresses, symptoms may become medically urgent and include autonomic dysfunction, hypoventilation, hemiparesis, and loss of consciousness requiring prolonged ICU admission. So let's move on to look at the role of imaging for localizing the eloquent cortex and white matter tracts. To localize the eloquent cortex, you can do functional MRI or magnetoencephalography or transcranial magnetic stimulation. Out of these three imaging modalities, the most commonly used modality is functional MRI. The one that is most frequently used is task-based fMRI. When performing fMRI for the purpose of language lateralization, it is important to perform a panel of tasks in order to improve the reliability of fMRI. Atypical language is more common in patients with epilepsy compared to healthy individuals. Some institutions have also started using resting state fMRI for language lateralization. Resting state fMRI has been shown to have reasonably good concordance with task-based fMRI, somewhere in the order of 60 to 70% agreement. So let's move on to localizing the white matter tracts. This can be done using DTI tactography. The white matter tracts that are of interest include corticospinal tracts, optic radiation, and arcuate fasciculus. So let's move on to look at the role of imaging to assess the epileptogenic zone. In patients with non-lesional epilepsy, that is, those with MRI negative epilepsy, functional imaging such as magnetoencephalography, SPECT, or PET is recommended. The International League Against Epilepsy has recommended additional tests for patients with MRI negative epilepsy, as well as those with specific lesions such as focal cortical dysplasia or tuberous sclerosis. However, it is not known which particular test or which combination of tests is the cost-effective diagnostic strategy. To address that question, we have conducted a Markov decision model to assess the cost-effectiveness of 6 different test strategies: PET, SPECT, and MEG individually and in combination. We have used sensitivity and specificity data from the study by Knowlton et al. The analysis was conducted from the societal perspective. The outcomes assessed include healthcare costs, quality-adjusted life years, and incremental cost-effectiveness ratio. We have found that in the base case, combined PET and MEG and the SPECT alone strategies were the cost-effective strategies. One-way sensitivity analysis showed that the model's decision was sensitive to variation in the sensitivity and specificity of the test strategies. Probabilistic sensitivity analysis showed that when the willingness to pay was less than 16,000 per QALY, combined PET and MEG was the preferred strategy. So to summarize, in this particular study, we have found that combined PET and MEG and the SPECT-alone strategies were the cost-effective strategies. However, the choice of test was dependent on the sensitivity and specificity of the test strategies. Based on these findings, we then asked the question, what is the diagnostic performance of PET and MEG at our institution at the Hospital for Sick Children? So to address that question, we have evaluated the sensitivity, specificity, positive and negative predictive value of PET and MEG individually and in combination in children with non-lesional localization-related epilepsy at the Hospital for Sick Children. We have found that combined PET and MEG has higher sensitivity compared to PET or MEG individually, similar to the findings by the study by Knowlton et al. Based on these findings, we infer that combined PET and MEG was a cost-effective strategy in patients with non-lesional localization-related epilepsy at sick kids. So we have reviewed a number of functional imaging modalities as well as structural imaging to identify the lesion and to localize the eloquent cortex and white matter tracts, as well as to localize the epileptogenic zone. At our institution, we would routinely integrate all these different imaging modalities on the neurosurgical navigation system. By putting all the data in the same 3D space, we're able to provide the surgeon with a 3D map of the relation of the lesion relative to eloquent cortex and white matter tracts and relative to the epileptogenic zone. All this data is then used for surgical planning. So to summarize, focal cortical dysplasia is one of the most challenging lesions to identify on MRI. Please be aware that there are patients who may present with focal epilepsy, but they are non-surgical candidates, such as those with POLG1 mutation or autoimmune encephalitis. MRI can also be used to help localize the eloquent cortex, such as with fMRI, and for localizing the eloquent white matter tracts, such as with DTI tactography. Functional imaging, such as with PET, MEG, or SPECT, can be used for localizing the epileptogenic zone. These imaging modalities are recommended in those with normal MRI. All these different structural and functional imaging can be integrated on the neurosurgical navigation system to provide the surgeon with a 3D map